Hello everyone, welcome back to my channel. This is Dr. Spinach. So in the previous video we talked about normal sinus rhythm, and I promised to make videos on abnormal sinus rhythms or abnormal ECGs. So this one is the first one on PSVT or AVRT. So before beginning this video, as always, I would ask you all to please subscribe to my channel. That encourages me to make more videos like these. So let's begin this video now. So this one, what's PSVT or AVRT? As its name suggests, it's paroxysmal supraventricular tachycardia or AV nodal re-entry tachycardia. Now, as its name suggests, what happens in PSVT? Now, normally, if you remember, the normal conduction of the pathway of the heart is from SA node to AV node to bundle of hairs and then to Purkinje fibers, right? So this is how a normal conduction of the heart takes place. But in case of PSVT, what happens is from SA node, the conduction goes to AV node, the impulses goes to AV node, but then from AV node, instead of going to bundle of hairs, there is re-entry of the circuit back into the atria. So a re-entry takes place. Normally it should go this way. From AV node to bundle of hairs, there shouldn't be any re-entry. But in PSVT, what happens is the electrical impulses bypass bundle of hairs and they re-enter into the atria. This is what's happening in PSVT. So you can imagine that how a normal ECG in this case will look like. If there is less depolarization of ventricles, then of course the QRS complex will be affected. The other affected features will be represented in the ECG. Now let's check the ECG for PSVT. Now please appreciate the rhythm first. Can you see that this is R, this is R? So R dash, let's say. RR interval has shortened. However, it is regular. So the RR interval in case of supraventricular PSVT will be shortened. RR interval. That why is it shortened? Because of increased heart rate. So it shows that it is increased. Why? Because there is re-entry of the impulse into atria. So before the ventricles could contract completely, the impulse enters back into the atria, then atrial systole, diastole, and ventricular systole, diastole. So that's why heart rate is increased, right? Now, the next thing is, can you appreciate the QRS interval? So it's more narrowed. QRS interval is more narrowed. So narrow complex QRS. You must be imagining where is P wave. There is no P wave. A normal sinus rhythm, in a normal sinus rhythm, P wave is always followed by a QRS complex. But here we can't find. This is QRS, and then this is a big wave, which doesn't seem like P, doesn't seem like T. Why? Because P and T waves are merged. P and T waves are merged. So P wave wouldn't be seen in this. So we say that there is hidden P wave. Okay? And finally, can you appreciate a depression in ST segment? So this is ST segment. Here, this is ST segment. There is a depression in ST segment, because a normal ST segment should look something like this. In case of PSV, you can see here the ST segment is depressed. Okay, so the final point here is the ST segment depression. Now, will you be able to identify PSVT from a normal sinus rhythm? I hope you do. Okay, now how do you prevent PSVT? Now, prevention of PSVT can be done by giving the patient verapamil. This is a calcium channel blocker. And if patient comes to you with this sort of finding, then in that case, the management is done by carotid sinus massage. In carotid sinus massage, we put our fingers where we take carotid artery pulse and then we move it in a circular motion for 5 to 10 seconds. Now, moving our fingers in a circular motion on the carotid pulse increases the vagal stimulation. If there is more vagal tone, what will happen in that case? It will decrease the firing of SA node and AB node, because vagus nerve innervates the conduction system of the heart. So when there is decreased firing from SA or AB node, there will be decreased heart rate. So we'll achieve what we want to. So the first thing that you do is a carotid sinus massage. Okay, the second thing we can do is chemical cardioversion. In this, we use IV adenosine 6 milligram in the first dose. If the ECG doesn't improve, you can increase it to 12 milligram. And if it doesn't improve, you can again increase it to 12 milligram. So this is chemical cardioversion. But even after giving adenosine, you don't get your result. The final thing that you can do is electrical cardioversion. In this, we give DC shock to patient, could be between 120 to 200 joules. So this is all about PSVT. I hope you understood what to see in the ECG in case of PSVT and what's the course of treatment in this case. I hope you enjoyed my video. I'll see you in the next one. Bye-bye.